All right, so how does ADH work? It's called vasopressin. Okay, well, its target is kidney tubules. And the tubules that are being targeted are going to be the collecting duct. Collecting duct and distal convoluted tubule. So here's my little tubule. Remember, these are kidney tubules, and they are made, or their epithelia is going to be simple cuboidal. Okay, got filtrate in here, right? Coming in here. Here's my blood supply over here. Okay. All right, there's my blood. So when ADH, and this is one of the hormones that are going to affect the distal convoluted tubule and the collecting duct as we are fine-tuning the urine that is going to exit. So when ADH is released, it's released, of course, by post-pit, posterior pituitary. So it is going to release ADH into the blood. So here's my ADH floating around in the blood. As it gets to the kidney, what happens? Well, ADH is a peptide hormone, so its receptor is going to be on the outside, and it's going to come over here and bind to its receptor. All right? When it binds to the receptor, what it does, remember, it goes through the, second messenger cascade, blah, blah, whatever. And ultimately, what it does is it stimulates vesicles that contain special channels in them. Okay? And they tell these vesicles to exocytose these vesicles and deposit them into the luminal membrane, so the membrane that is along the lumen of the tubule. Now, the collecting duct and the distal convoluted tubule are not permeable to water. So as the filtrate's coming down here, it is dilute. It's fairly dilute. It's just coming out of the distal convoluted tubule and coming down the collecting duct, and it went through the loop and all of that, and so it's pretty dilute right here. At the most, it's going to be 300 milliosmoles because everything in the cortex is isoosmotic. So at the most, it's going to be that. But as it comes down, if you remember from the anatomy of the tubules, that this collecting duct is sitting in that crazy gradient. If you remember, this is the medulla, and medulla going down is getting really salty, right? So, 400 500, 600, 700, 800, 900, 1,000, 1,200. So the filtrate is going down this collecting duct and down towards the bottom of the renal pyramid to the papilla, and it is in this, this gradient, this weird salty gradient, and at the most it's going to be about 300 milliosmoles, but it could be less than that. And so when ADH is there, it will get these aquaporins, which is what they're called, if you remember that term. And aquaporins are specific to water. So as the filtrate's coming down here, the water's going to leave because it's going to go into this higher, higher concentrated area. It's going to follow the solute, right? So water is going to leave the filtrate. And it will end up being resorbed into the blood. And that will increase blood volume, which will increase blood pressure. Okay? So ADH increases blood volume, and that will make the vessel stretch again, and then it will shut off. Okay, the hypothalamus will be, okay, cool, good, done. Negative feedback, normal negative feedback, and then we stop having ADH released. Okay. So ADH increases blood pressure and blood volume by stimulating the kidney to reabsorb water. Okay, so that's how ADH works. So now we need to look at aldosterone. So we'll look at that next.